mptp.pakistan@gmail.com, and also fill the feedback form. Link will be shared at the end of the session. Presentation will be shared on Monday, inshallah. No, sir, we can take the questions. So anyone
Yes,
want
we
to
can
ask?
take.
Hello, I am Asad Zamir.
Hi,
Hello,
Asad
sir.
Zamir. Assalamu alaikum.
Walaikum
How are you?
salam. Yeah, fine. This presentation was very informative because
Thank you
most
so
of
much.
us don't, yeah, in Pakistan, most of us basically don't have too much idea about the radiobiology. Uh, by this presentation, we can improve ourselves. I have only one or two questions.
Sure.
What about the radio surgery? Means in radio surgery, we make most of the plan on isodose line. So
Right.
sometimes we used doses 500, 600, 700. So there, how we will calculate the gap?
Yeah.
Is it
So
a
Asad, yeah.
same method? If it is a same method, then is there any guideline or reference that we can reference to
So
anyone? Yes, we are
yeah.
using this guideline to calculate the gap.
So let me tell you one interesting thing, Asad. Here, in when we are doing SBRT and SRS, we are using the concept of tissue ablation. So what we
Yeah.
are doing is, and inshallah tomorrow when we discuss the 4 hours of radiobiology, please have, I think, if you all can sit with me tomorrow, and if we go beyond 1 hour, I think that will be good for all of us, because I want to discuss these concepts. We give
Okay.
time
And
to,
other,
no, let me let me complete the answer. So we give
sorry.
time to normal cells. We give time to normal cells to repair themselves before hitting them again the next day. The concept of fractionation. But in SRS and SBRT, we use the concept of tissue ablation. Ablation means we are just destroying them. We are just killing them. So SRS is a single fraction. When the tumor is less than 2 centimeter, we go to 2000, in brain, we go to 2400 centigrade. And if it's bigger than 2 centimeters, say, we can decide to go to 1800 centigrade, because we are looking at uh, D12 also. So we are looking at the other parameters. But this SBRT and SRS treatment, unfortunately, we don't have any radiobiological data for that. So based on our survival fractionation and our curves, and based on the fractionated scheme, we cannot explain SBRT and SRS. We are basically, in these concepts or in these treatments, we are just destroying the cancerous tissue. We are hitting it with, you can say, we are hitting with a hammer. And as in Urdu, we say, so sunar ki ek lohar ki. This is the one from lohar. We are just
Okay.
destroying it.
Okay.
Okay, what is your
Yeah.
second question?
Second question is about transformation, because nowadays people are talking about the squidal cells. Means they are transforming some kind of like stem cells, squidal cells, and such kind of things. Like it's belong to the immune therapy, you can say. So
Right.
what do you think? Is there any difference between them? Because we are mostly working on the radiation, but maybe in future 10 year or 8 year, we skip the radiation. We just start to doing the immune therapy and such kind of thing,
Yeah.
because there is very less side effects in targeted or
Yeah.
immune therapy.
So yeah. So actually, what happened, Asad, is like this concept of getting rid of all the radiation is a very old concept. In 1990s, internationally, when the computers became available commonly, they started developing. You may have heard of that project when they were working on developing, I think, the gene model. And
Yeah.
everyone was so hopeful, when this gene model is complete, cancer will be history. Because as I said, there is a gene in the cell that decides that if the cell is fit to go into division or not. So if we know about that gene and we can control that gene, cancer is gone. But the problem is, this idea have been, I mean, I think for as long as radiation has lived, this idea has lived that one day radiation will be history. But this has not happened yet. And when I joined the field when I was young back in 95, this was the concept that one day radiation treatment will be gone and we have to take some other, for our personal things, we have to take some other
Well
field.
said,
But now
Manoj.
I am here, and
Okay,
we
last
still are
question
working.
is,
Uh-huh. Right.
yeah, because we are a physicist, we can fit everywhere. My last question is
Exactly.
regarding
Yeah.
different
Uh-huh.
organs. Like uh, when we talk about the
Right.
gap calculation, so during gap calculation, should we consider the organs like you put the same formula for brain, same formula and same factors for prostate, same for lungs. So is there any delay factor or such kind of factor that we can use during calculation?
So there is another concept for delay, that is Sasek and Boni. I'm trying to get my hands on that paper, but I couldn't find that paper. They are using the alpha beta equation, and they have introduced a concept of K, a constant K,
Yes.
which
Okay.
is yeah. So that
0.66.
exactly, yeah. So that K will it's kind of a delay factor in the Sasek and Boni linear quadratic equation. But at the end, both the equations, the delay equation that I discussed and the Sasek and Boni linear quadratic model, they predict more or less the same decay or delay. So it wouldn't matter, it wouldn't affect your calculations a lot if you use one or other. If I get if I get my hands on Sasek and Boni, I will create an Excel sheet for that also. But until then, and there's a little difference. We are using the same here also. Whenever my physicians ask me to calculate decay or delay, I use the same Excel sheet. So you guys can solidly use it.
I want to ask one more thing in continuity with this question.
Uh-huh.
Suppose when you calculate the doses with the gap calculation, then if you are delivering 200 CGY per day, after gap
Right,
calculation, suppose you calculated 220. So
right.
should we make a new plan for these dose, or we just put with the addition of 20 CGY with the previous plan?
Uh, yeah, actually, with mostly with Pinnacle and Eclipse these days, they are controlling the machines. So yes, we have to create a new plane, because what Eclipse is doing these days is they have made it very difficult for us. We have to retire the old plane, create the new plane, and then make that new plane like treatment approved. And there are two kind of approvals for that. One in my dosimetrist does, and I do the treatment approval. So when we treatment approve it, then it is deliverable. So if you only do increase the dose to 220, the MUs are definitely going to change. And if you and I would recommend that most of the centers should have a verify and control system like ARIA or Mosaic. So if you are using ARIA or Mosaic, they have to use the plane from the computer to deliver that treatment. So the answer is yes, we have to create a new plan.
Okay,
And
so if someone
and
don't want to create new plan, he or
it's
she
easy.
just
Yeah. Let me
he
tell
or
you, Asad,
she
one thing.
just yeah, okay, continue.
What you can do is, if even if you have an IMRT plan, change the dose, and instead of re-optimizing, recalculate. That will save you time also, and your parameters are the same. Your code doses, everything is the same. You have just recalculated for 220 instead of 200.
Asad bhai, can we take a question of other participants?
Yes, why not?
Because they
Thank
are
you giving me
waiting.
time. Yeah,
Okay. Thank you, sir.
It
thank
was
you.
nice talking to you, Asad Zamir. I've talked to you on cell phone
Same to you. Thank you.
sometimes. All right.
So
Yeah.
next question, if anybody have the any question, he can unmute himself and ask the question.
Assalamu alaikum. My name is Dr. Badar, and I'm a radiation oncologist. First of all, thank you so much for refreshing our knowledge regarding radiobiology. I've just a small query regarding the linear quadratic model. Till what fraction size does it hold? Like we use the fraction size usually the conventional 1800 or 2
200, right.
1.8 or 2 gray. Yes. But in cases of some palliative radiotherapy, we also use 8 gray single fraction. So does it hold till then?
So it holds up to 600 centigrade. You can use it very confidently up to 600 centigrade. But 800 centigrade in a single fraction, I think, and Dr. Badr, you may know better than me, that we are going into the phase of tissue ablation. And we are talking, when we are talking about tissue ablation, then our radiobiological models fail, or or they are not predicting anything as of today. So when we
Right.
are delivering 800 centigrade in one fraction, that's kind of tissue ablation.
Right. We actually use it in the palliative setting, and that too within the constraints of the tissue organ, and for the time constraints actually. But most of the times we are using 30 gray in 10 fractions or 20 gray in 5 fractions for the palliative setting. So
Right, right.
very
Yeah,
rarely
so
8 gray single fraction is used.
800, yeah. So 600, like the textbook says that we can use it confidently up to 600. Um, I
Right.
have done 800 myself, like I have seen 800 myself. So it's not
Yeah.
something out of ordinary. And I think we can still use the equation for 800, but for 600, that's recommended by textbooks. And 800, there is a need, and definitely some patients need it, but that will be the gray area. But definitely we should use it when some patient need it, we have to deliver it.
Right. Thank you. Thank you for your
Yeah.
time.
Thank you, Dr. Badr, and thank you for attending the physicist PowerPoint presentation.
Right. It's always a teamwork, sir. It's always a teamwork.
Exactly, it's always a teamwork.
Thank you, sir. Do you have any other question? You can unmute your voice and ask the question.
Hello.
Hello.
Hello. I have a question.
Sure.
You mentioned both proliferating and non-proliferating cells. Could you kindly give examples of what these cells are? And then secondly, how would you be able to know when a cell is at the M phase or the G2 phase? Because you said this is when they're more radiosensitive. How can you be able to tell when they're at this phase?
Okay, so Dr. Badr, can you come to my help here for explaining proliferating and non-proliferating cells, and then I will come to the point to your second part of your question.
Right, in general terms, the cells which have shorter lives and they are continuously dividing, they are usually the germline cells, like in ovaries and testes in cases of males. For that reason, the dosage, the overall dosage to these organs are very low as probably 1 to 2 gray to destroy completely these organs. However, the neuronal cells of the brain and the bone cells, they are usually the ones which are resistant in terms because they are not continuously dividing, or they are kind of in a shield, in a cell bunker, you say, and they needed higher doses of radiation to get the effects, sir.
Thank you so much, Dr. Badr. And what was the second part of your question? Sorry.
The second part was, you mentioned the cell is more radiosensitive in the M phase and the G2 phase.
Yeah.
How can you
so
be able
actually,
to tell?
yeah. So we actually, when we are delivering radiation, at that time, we don't have a way to know how many cells are in which stage. So that's why we go to fractionation. And please attend the tomorrow's session. I will be discussing the 4 R's of radiobiology. So after those discussions, it will be more clear to you that the reason we go for fractionation instead of a single fraction is to wait for those cells which are in, let's say, in G1 phase or S phase, and which are not ready for radiation hit. We wait for them to go through the cycle and go into late G2 phase or M phase, so they will be good for our hit. So that's one of the reasons for our fractionation, to wait for the cells to go through their cycle and be ready for our treatment. So definitely we don't have a way to, there are billions of cells when we are hitting a tumor, and we don't have a way to predict about every individual cell. And at the same time, we have to kill every individual cell.
All right, thank you.
So
Another
I
question,
hope
the link for tomorrow's.
uh,
Hello. Will
I
this
think
be the same link
Asad
for
has
tomorrow's
Asad.
lecture?
No, I think it's a different link. But Asad Yusuf, have you shared that link?
Yes, sir. We will be sharing the link for tomorrow's session, inshallah, in a while.
Oh, okay. So you will email it to everyone?
Yes, we will email it to everyone
Okay.
who's present there.
Thank you so much.
I am posting in the chat box right now too, and we will also send a reminder for that.
Assalamu alaikum.
Walaikum assalam.
I'm resident of radiation oncology from Aachen. I have a question regarding dose calculation. As we discussed earlier in the presentation regarding dose calculation of gap for the tumor tissues. Now, what about
Right.
the normal tissues like late effects and normal and the acute effects? What about the calculation for them?
So when we are talking about gap calculations, and as we do fractionation, so we are actually taking care of the normal tissues at that time. And because of the gap, the normal tissues have definitely repaired themselves. So that is one part. The second part is when we increase the dose, I think your worry will be that once we increase the dose, we are hitting the normal tissue more.
Yes.
So we don't go crazy about increasing the dose. Like we can increase it from 200 to 210 or 220, but if the gap is longer, and let's say we go, let me go back to one thing. If the gap is 10 days or 10 days or 20 days, then the delay factor will give us a decay of maybe 60 centigrade or 70 centigrade. So we can add those 60 or 70 centigrades to the remaining days, and increase the dose from 200 to 205 or 210. But if the remaining dose becomes 170, 180 or 200, then we deliver that as a separate fraction. We don't go we don't go to 250 per fraction or 240 per fraction to increase the dose widely. We will just add another fraction. So adding that another fraction will be a day between the last plain treatment and the additional treatment, and that day will give sufficient time to normal cells to repair themselves. I hope that answered your question.
All right. Thank you.
Sir, I have a question. Could I ask?
Sure, yes.
All right, sir. What I've understood from your answer is the remaining dose might be delivered in another fraction or two.
Yeah.
Could we deliver? Could we do in? I mean to ask, could we increase some dose? Let's say we were going with 2 gram fraction. Could we go with 210 CGY, 210 CGY a fraction? Would
Right.
that be
Yes.
equivalent?
So if you have a lot of fractions, let's say you have 8 fractions left, and the decay is 80 centigrade, the delay is 80 centigrade. So we can add these 10 to the remaining 8 fractions, and we can deliver 210 to every day. So it will be the team decision between physicists and physicians. They can sit together and decide um, how much we can increase the dose safely. Like, let's say, do we need to go to 220? Because what will be the biological effects of 220 on normal tissues? If not, then if our delay is 170 or 180 or 200, we can deliver that as a separate fraction. So it will be good. If our delay is up to 150, 200, we can deliver a separate fraction. But if it is less than that and we have a lot of remaining days, we can spread that through the remaining treatment.
Thank you, sir.
You're welcome.
Do you have any other questions? Kindly you can ask.
I would add one more thing. If I was speaking too fast, or there was something that you guys would recommend for me to change, frankly, you share on our site. There is MTP.
Yes, we have MPTP platform.
MPTP. So you can please give your suggestions on MTPT. So MPTP, I can change my way. If I'm speaking too fast, I will slow a little. Or if I'm not able to explain some of your questions, please ask them again or MPTP, and I will try to explain them in detail. And
We have a
tomorrow,
question, sir. Sir, we have a question from,
okay, sure.
I think, Radiation Oncology Training AKUH. Madam, you can ask your question.
Thank you, Jawad. This is not a question. This is Dr. Bilal from Radiation Oncology, Aachen University. I want to thank you and all the organizer and Ahmed Ali Saab for organizing this talk and giving a very important highlight of this important topic, which is very pertinent to our patients, especially for those whom we treat with radical intent, like squamous cell carcinoma of head and neck region and gynecological cancer, because we know that recurrence rate rises whenever there is unintended treatment gap in between, and the gap should be calculated to have comparable outcomes. So it was very useful for our entire team, not just the medical physicists, but all our radiation oncology residents, especially the first year residents, also attended and found it very useful. So
thank you so much, Dr. Bilal.
Thank you so much.
Thank you. I really appreciate your kind comments.
Any other question?
I have shared tomorrow's session link in the chat box, and I will further also be sharing it on the WhatsApp. So wants to copy from here can copy from here for tomorrow's session, and otherwise it all be shared on the WhatsApp.
Okay, thank you, madam. I think it's enough for today. We will
Okay, I have
join
a request.
tomorrow and send.
Jawad,
Yes, sir.
I have a request for tomorrow. I have I would we will be discussing some important concepts tomorrow, and some very important things. So if tomorrow, if you guys can sit with an intent to sit a little longer, I hope we will finish in time. But if not, I want to, especially for the students, I want them to have concepts. So tomorrow's discussion will be alpha beta ratios and all 4 R's of radiobiology and all those things. So if we can sit a little longer, that will be great. So what we can do is, for those of you who think that 1 hour will be enough and they have some other appointments, they can leave, and those students and those colleagues who want to sit and stay with us for a little longer, they are most welcome. And if not possible, we can arrange another session again next week or in a couple of weeks, and we can talk to Asad Yusuf for that.
Okay, sir, for sure. I think we have tomorrow. We have same timing, and we will
Yes.
continue this the topic from the today's where we left. Thank you, sir, for your time you spared
Thank
for
you
us.
so much, everyone.
We learned actually. I always learn from my teacher and my mentor, and today my other participants are also here. So thank you for your time.
Hello, can you hear me?
Yes.
This is Dr. Kashif Islam from Genome Cancer Hospital. I have a question related to biological effective dose.
Right.
At one point, it was mentioned that alpha D is equal to beta D square. That
Right.
means single hits and double hit, they become equal. Is there any way chemically, biologically to quantify that equivalence? Can we do some kind of experiment for that purpose?
Dr. Kashif, definitely there is like in the books that I studied for this, we talk about radio protectors and radio sensitizers. So what radio sensitizers and radio protectors do is they change the behavior of cells towards radiation. There are chemo regimens like in radiation we have there in some cases, like our radiation oncologist friends will be more aware of those chemotherapy and those tumor sites that we do concomitant chemo and radiation. So first we send patient to chemo, they deliver a chemo dose, and the tumor become more radio responsive. It gives more response to radiation. Then patient comes to us to radiation department and we treat the patient. So we can alter these with chemicals, with the chemicals of chemotherapy. And it's an ongoing research. In the United States, back in the days of Cold War, they were distributing iodine pills. So if iodine pill, now we know that it's not a great idea, because iodine will only go to thyroid, and it will protect thyroid from more radiation if we from inhaled radiation, but inhaled or ingested radiation. But again, it was an effort to protect people from any attack if it happens. So yes, with chemicals, we can do that. And it's an ongoing research, and definitely the organizations that have funds, that have access to all these experimental animals and all the chemicals, they are doing those research. Next question. Hello?
Sir, I have a question. That the 4 hours, when we talk
Right.
about the 4 hours, it is only applicable for fractionation treatment, or it is also applicable for SRS or SBRT?
So for SRS and SBRT, we use the idea of tissue ablation. So no, these are not applicable there, because in SRS, we just use a single fraction. And by tissue ablation means we just destroy that tissue. Now, if you think of normal tissues here, with the MLCs, with the invention of MLCs and with the new technology and the treatment of rapid arcs, and also with CyberKnife, we are using so many angles that the dose to the normal tissues is reduced a lot, and we kind of annihilate the tumor, and at the same time we are sparing the normal tissue. If you for those of you who have seen the isodose lines, the DVH for an CyberKnife treatment or SRS treatment, they look really beautiful. We treat a tumor very close to the eyes, and the dose to the eyes is almost none. We are treating a tumor close to the cord, and the dose to cord is almost none. So the accuracy is main thing here. We need to be more accurate here in millimeters. So here the physicists need to keep their machines tidy. I shared in one of my monthly QAs on our forum sometime back. If you look at that for physicists, if you look at that again, there are a lot of diagnostic checks. There is Winston Lutz check that check isocenter at different gantry angles to make sure that our gantry is rotating within 1 millimeter. So we are talking sub-millimeter accuracy here for SRS treatments. And similarly, SBRT, when we deliver 1000 centigrade in 5 fractions or 1700 centigrade in 3 fractions. So what we are doing is we are just bombarding the tumor, we are eradicating it, and we are sparing the normal tissue a lot. So the concept of radiobiology or the 4 Rs is not applicable here. And to be honest with you, at this point, we don't have sufficient data for these kinds of treatment as well. So as we treat, as we go on, and with the passage of time, we will start getting results. And I want to add one thing, that the idea of increased fractionation, like we treat breast with 340 times 2 in 10 days, or there is a new regimen now, they are treating with increased dose and less fractions. Similarly, if the dose for prostate came down from 45 fractions to 27 fractions with increased dose per fraction. These are all because of advancements in the concept of or in the research on alpha beta values. So when we do research on alpha beta values and we see that for example, for prostate, the alpha beta may be the same for prostate as for bladder and rectum. So we can use a different approach. But for some tumors, for example, in head and neck, there are so many things involved, so many other organs, that we may not be able to accelerate the dose. So the concept of hyperfractionation and hypofractionation, we can use radiobiology concepts, but for SRS and SBRT, no, we cannot use them. Next question, please.
Hello, sir. Good afternoon.
Hello, your voice was breaking.
Yes, sir. This is Manoj Kumar from NCCI Hospital. Sir, my question is regarding overall treatment time. Sir, can you hear me?
Yes. Now I can hear you, Manoj.
Yes, sir. So my question is regarding overall treatment time. So, for example, we have a patient of head and neck cancer with the 2 gray in 35 fraction. So, is it important that we have to give the prescribed dose 70 gray in 7 weeks? That is within 50 days or 48 or 49 days. Otherwise, what happens
Yes.
is the TCP, the tumor control probability reduces by a certain percentage. That is, I guess, 1.5 or 2%.
So Manoj,
So is it true?
yes, this is Manoj. This is like, for that we have to calculate the decay and see what was the rest time. So 1.2. I cannot say yes to 1.2 that exact number, but yes, it is important to deliver the dose in the planned number of fractions and the planned number of weeks. If the patient,
yes, sir.
if the patient goes on rest, or sometime the blood counts go low and radiation oncologist will send them on rest, then compensate for that missing dose. Calculate the decay in the dose.
Sir, irrespective of any conditions, in general, I'm asking whether it's important to be delivered 70 gray in 35 fractions within 50 days.
In 35 fractions, so 35 fractions are how many weeks? 35 fractions are
within
7 weeks,
weeks,
right? So,
yes, sir. So it's 49
yeah, so
days,
49 days. Yes,
sir,
yes, it is important.
my second question is, when the patient goes on rest due to any problem, and he comes after 10 days or 8 days, so the overall treatment time could now be 58 days or 60 days. So can we see that the tumor will be compromising, the tumor control probability will be compromising, or there could be the chance of recurrence in this scenario?
One of our radiation oncologist friends, if someone is hearing, will be better able to address this issue. But as we discussed, when patient goes on break, the tumors are repairing themselves. Sorry, go ahead. Yes.
Yeah. Yes, sir.
Yeah. So the tumors are repairing themselves. So the radio sensitivity of the tumors increases, and at the same time, the tumors have repaired themselves. So yes, the probability of recurrence increases, and the overall effect of our radiation dose decreases. But if some of our radiation oncologist friend can come to my help here to discuss it exactly what happened in head and neck case, that will be really appreciable. So Manoj, I think here we can stay with my answer.
Okay,
That is yes. Yes, the tumor resistance increases because tumor has repaired itself, and the recurrence chances increases. So it's
okay,
good to
sir. It will
deliver the
depend
dose.
the clinical decision.
No, I mean, always compensate for the missing dose. Always compensate for that. But whenever
Yes,
a
sir. That's
fraction, whenever the treatment is not delivered in the planned fraction, we are giving chance to the tumor cell to regrow, and the chances of recurrence increases. So the answer to your question will be yes. Next question.
okay, sir. Thank you.
You're-
Assalamu alaikum.
Walaikum assalam.
Ali, this is Abrar from New York.
Hi, Abrar. It's good you are attending my talk at this time.
Yeah, actually today there is another session and I was preparing for it. It is also with the Pakistani students, so I could not attend whole your presentation, but I have simply a comment. Some of our physicists and maybe radiation oncology physicians are also there. We physicists, we fight for 1 millimeter and less than 1% uncertainty or differences that we try to make up corrections of 1 millimeter and other things also. At the same time, there are two very important things like contouring, where doctor can contour a couple of millimeter of the target, and some meticulous doctors, they draw exactly the target. But anyway, it can happen with anyone. A contouring, number one, and number two, missing fractions. Like sometimes a patient is not able to make it every 5 days of the week. So in case they are missing a number of fraction during initial days of treatment or towards the end of treatment, and let us say that patient has missed 3 fractions in initial and 3 fractions towards the end, or other way around, 6 fractions are missed towards the end. Something happened, patient has gone to some relatives and they missed that many fractions. It is a huge difference, and it should be brought in notice of families that when they miss this fraction, how big impact it brings. We physicists, we keep on fighting for 1 millimeter and 1%, while this thing, it will anything when patient, they lose a few fractions, and again it depends that the, by the way, could you tell that 3 fractions missed in initial stage and few fractions missed towards the end of treatment, which one is more impactful?
So, Abrar, towards the end of the treatment, we have done more damage. In the initial, let me go to one basic idea. When we are treating some emergency patient for spinal cord compression, we don't treat one fraction. If patient comes on Friday, then we usually treat on Saturday also. So initially, if we deliver one dose and the patient goes on rest, that dose, the whole dose is kind of decayed. But towards the end of the treatment, when the patient goes on rest, we can calculate and have some change. So initially, it will be bigger effect, and later on, the effect might be smaller. But overall, like in alpha beta calculations, I have not seen any paper that addresses this differentiation of where the break occurred. So overall, what we do is we try to compensate that with our equation, and we try to compensate the missing dose. But where the break occurred, we still don't have any equation for it, and research is going on. Definitely we will have clear answers in the future. But right now, all we can do is we can just calculate missing days. And yes, in the beginning, if the patient comes for one treatment and then goes for rest, that treatment is gone. Technically, that treatment is gone. But we just cannot give that treatment or add the whole fraction because a patient went for rest for 1 day. We have to calculate the all based on this equation that we discussed, and add those accordingly. So the answer to your question is yes, there is a difference. But again, at this point with our research, we don't have a way to differentiate that difference and put it in numerical numbers.
Yeah, but for sure, sometime a very unorthodox number of fractions are missed. And in that case, actually, we are not treating tumor. It is merely a palliative treatment. Actually, there was a case, and I had a very long calculation with one of our radiation oncologists. And we end up that right now, the number of fractions, the way those are missed and the way we are treating right now, we cannot make it like it is no more curative. It may be a palliative though, but it is no more curative. Number one, and number two is keep in mind that when there are very many number of fractions are missed, and then you do your calculations, and that compensation which you are calculating, it will be very high number. Like the difference, it will be not 600 centigrade miss. No, you have to give a lot more than 600. So that way, your normal tissues, you are going more than tolerance of a normal tissue also.
So in that case, Abrar, sorry to interrupt you, but in that case, like if a patient goes on such a big break, like the break here we discussed in these calculations is 28 days. For 28 days, it's about 180 centigrade. That scenario that you are talking about is months. So once a patient missed treatment in months, basically, and did not get complete treatment, I have seen a complete recurrence. And it becomes a scenario, number one, it becomes a scenario of retreat. And number two, as you said, it becomes a scenario of palliative treatment, because now we are not treating the initial tumor, but we are treating the recurrence. So the equation totally changes at that time. We are treating the recurrence and we are retreating, and then it will be a palliative treatment.
Hello again. This is Kashif Islam again.
Yes, Kashif.
May I ask you? The Abrar was saying something about contouring being done by radiation oncologists. Is there any quick way to do contouring, keeping in view the recent technologies? Yeah.
Yes, the softwares like Eclipse and I think Pinnacle also, they come with databases now. So you can just once we import a scan, we can tell the software that it's a head and neck scan, and the software will put all the contours that are needed. And once those contours are needed, we just need to go in and retouch those. For tumor, when we do a PET scan, there is a fusion software that is called MIM, MIM. MIM does a very good job of marking tumor from the PET scans. It works on SUV number of the PET scan, and then I have seen it doing magic.
By the way,
Assalamu alaikum. Thank you everyone for being here. And
can I ask one question, please?
Sure, please go ahead.
Okay, it won't take more. So first of all, thank you very much for your time, sir. My name is Abid Ali. I'm working at SQCCC. My question is, So do we have any quantitative data regarding the biological significance if we are treating something very aggressively in the radical regime? Like most of the time we are treating like 5 days per week, and like if you go aggressively like 6 days per week, so what will be the effectiveness for the for this regime? Is there any data?
So Asad, sorry, did you say Asad or Abid? Abid, yeah, Abid. We have like, because mostly in Europe and in United States we only work 5 days a week. So most of the research is done for 5 days a week. So for 6 days, I think we can. I will check for you if we can use our alpha beta ratio for that. But our data is for 5 days a week, and so when we are talking about 5 fractions, so we are talking about 5 fractions in 7 days, or as we discussed earlier about head and neck, when we are talking about 35 fractions, so that is 35 fractions and 7 weeks, not 35 fractions and 35 days. So when we are treating more, I think theoretically we should be doing a favor to the patient, because we are not giving 2 extra days for the tumor to repair itself. But I will see if we can do that with alpha beta ratio and see, and I will try to research some literature for you also. But at this point, our research is mostly 5 days, 5 fractions in 7 days.
Okay. Because the question arises because you need, if you study radiobiology, 4 hours of radiobiology, there's a concept of repopulation. So
yes,
treating 6 days per week, that means that you are not allowing the normal cells to repair like almost 1 day,
so
and to repopulate
so
the tumor also.
most cells have a time of 6 to 10 hours. So on normal cells, we are still allowing them we are giving them the 24 hours to repair themselves. And at the same time, we are hitting the tumor again. Instead of giving it 48 or 72 hours to repair itself, we are hitting it again within 24 hours. So my personal opinion is we are doing a favor. But again, I will look at the numbers.
Okay. Thank you very much, sir. Thank you very much.
You're welcome. You're welcome, Abid.
Thank you.
Okay, everyone. Assalamu alaikum from me, and thank you again. Thank you very much for letting me talk to you all and attending the talk.
So
It was really nice to.
If
Sorry?
you can wait for a while, Mr. Kashif, Dr. Kashif will add a concluding remark for the session.
Oh, okay. Okay, sorry, I didn't know that part. Sorry for that.
Oh, no problem. Thank you very much, Muhammad Ali Shah. This is a great opportunity to have you for these 2 days. We have been here in our afternoons, and everybody will be at different time zones. I'm so thankful for your time and effort that you have extended for us. And definitely we have learned a lot. Everybody has brainstormed his or her basic knowledge about radiobiology. It was really fun to have the same equations, and we have thought about all the process which is required to be considered during those equations and solutions. I would also like to thank Mr. Abrar. He has added quality discussion at the end. And at the end, I would also like to thank all the participants who have really spent good quality time in this presentation. Over to you, Jawad.
Thank you, sir, for adding very good comments. Inshallah, we will share all the lectures detail, the Excel sheets and the recording to you on our WhatsApp group, and also we will mail to all the participants. Thank you so much, Muhammad Ali Shah sir and Dr. Kashif.
Thank you so much, everyone. And hope we will see each other again, inshallah, at some point. So please feel free to contact if you have questions.
Thank you, sir. Thank you very much, sir.
Thank you.